Good morning. My name is Ed Berger, and I'm going to host a conversation today about healthcare as related to Taylor's sermon on poverty and the poor. Certainly, wealth has a tremendous influence and impact on the ability of people to obtain quality, timely, accessible healthcare, and that's what this conversation is going to address this morning. Um, my name is Ed Berger, if I didn't say that already. I've been a member of First Church now since 1990. As an adult, I was a kid in an MYF class and Sunday school class in the mid 60s at that church. For about 25, 26 years, I worked for the Seton healthcare system in Austin, and I had a fair amount of experience on healthcare policy because I was working with legislators and folks in Washington, D.C. about healthcare policy. So I encountered my friends here today with us, Anne Dunkelberg, who was with the Center for Public Policy Priorities. That's how I knew her, but now it's called Every Texan, and I'll let Anne talk a little bit more about that. And I know her as a wonderful advocate at the state legislature for all things for every Texan. That really is a good way to capture it, and she'll talk more about that. Dr. Chris Ziebell came to Seton as an emergency room physician in the late 90s. I knew him when he came. I continued to appreciate his friendship and his expertise. He is the director of emergency medicine at Seton Dell Medical Center, a new hospital that was built right next to UT in Interstate 35. So I think the first question I will ask started is for Anne. Why don't you introduce yourself and talk a little bit about what you do and what your passion is and how your faith history, story, whatever might influence your work.
Thank you, Ed. Thanks for the invitation to be part of this conversation. I have worked in um, advocacy for healthcare access for quite a long time. I grew up in Austin, and I had the good fortune, after taking a few years off after undergrad, to go to the LBJ school and get a master's in public affairs there. And ever since then, I've worked in the area of access to healthcare. Did some work in the actual Texas Medicaid program during the Ann Richards administration, and then, believe it or not, have worked for Every Texan, formerly the Center for Public Policy Priorities, since 1994, working on access to care for the uninsured, for non-citizens, et cetera, and get to work with a great team of people there. So how I came to that, my dad was a doctor. I was raised in a home where social justice was part of the language we spoke, and I dropped out of medical school too. So I think at some point I figured out that I was really more interested in the social justice aspect of healthcare than I was in being a clinician, and it's probably did everybody a big favor by doing that. Also, just wanted to mention that uh, my grandparents are all either Methodist or Presbyterians, and I think that the Presbyterians only became Presbyterians because there was a Methodist minister, back in the first part of the 20th century, who got tired of being moved around all the time, which I believe was the case for Methodist ministers, at least back then. So he became a Presbyterian to get out of all those moves. In any case, my faith perspective is probably messy and complicated, but uh, I think one of the values or phrases that I've had in my head for a long time is the notion that if people need to be able to um, do some role playing with themselves and imagine what if they were visiting with St. Peter or Jesus or whoever, how they would explain their positions on health policy to them, what would be persuasive. And I think one of the things that's occurred to me in recent years is, how do we even defend the existence of the pursuit of medical advances and medical expertise if our intention is not to share it with the entire human race? How is that in any way defensible? And that sort of underlies how I approach the healthcare advocacy piece. And that's probably more than enough.
Well, I was going to say that's a very strong faith statement. Thank you. Thank you. Chris, how about you?
Yes, good morning. So as Ed mentioned, I'm an emergency physician. I came to Austin in 1998 and joined the Seton Healthcare family at that time. I've been medical director of 3 different emergency departments. Well, 4 if you count the new hospital as being different from the old hospital it replaced. Since that time, I've also been on the Seton Board of Trustees almost continuously from the year 2000 until now, when I still serve on the board with one little interruption from 2017 and 2018. I chair the clinical quality committee of the board, and as a board member, I've been honored to be able to participate in a multitude of discussions around the mission and vision of the Seton Healthcare family, which is now Ascension Health, and really to find myself inspired by the way that they've approached healthcare and the way that they've focused their priorities on people who can't take care of themselves. They use the words poor and vulnerable, but I think we spend at least as much time on each. So it's not that they're vulnerable because they're poor. I think we see vulnerable in a number of different ways, and so to sort of see that and to see how those decisions are made at the strategic level, it really is inspiring, because unlike a lot of other healthcare entities that I've been a part of over my career, we put people first and the money takes care of itself.
Thank you, Chris. Could you both speak, and I'll pick on one of you to start, to the intersection of poverty and race as it affects healthcare access and outcomes? And then secondary to that, how has poverty and race affected COVID-19 outcomes this year from your perspective? Chris, I think I'll start with you because you've been on the front line with that since it all began in March.
So the first thing that I'll say there is that I've really been trying hard to sell the message to those around me that there's a cost of doing it wrong, and to look at the success stories where we change the way we do things and provide better care to people, and in doing so, it actually saves us money. So so that's the first thing, is that for example, if I'm 55 years old now. I've recently had the pleasure of having had my second colonoscopy, which was scheduled and recommended by my PCP, who sees me on a regular basis and makes sure that I get the health care that I need. It cost me and or my insurance a couple of $1,000s to do that. Were I not a person of privilege and success, I probably wouldn't have that colonoscopy, and the system would find out about me when I develop colon cancer, when I need a major surgery to resect that colon cancer, when I need very expensive chemotherapy and whatnot. And society's reward, or my reward for all of that, is that I would cost a lot more and I would live a lot less. And that really is where the intersection of poverty comes into the healthcare picture for me, because as an emergency physician, I see all the ways that things go wrong, and that has been even more accentuated in the era of COVID, because now what I'm seeing is poor Hispanic families, for example, that have 6 or 8 people who live in one household. They have one wage earner who cannot afford to take any time off, because that one wage earner is responsible for the lives of multiple other people. And so they go to work and they get COVID at work and they bring COVID home to their families. And we have families where 2 or 3 or 4 people from the same family are in intensive care for weeks at a time. And all of that is going to be very expensive care for the system, and it's almost surely going to be uncompensated care, which means that all of the rest of us, thinking that we're saving money by denying these people good health insurance or even Medicaid, are actually wasting our money because we're forcing the system to force these people into very expensive care instead of taking care of them on the front end.
And what about from your perspective?
Well, I mentioned before that I've been doing this work for a long time. And when I first started doing this work, we used to get advice from people that in Texas, we didn't want to acknowledge the racial disparities of who was affected by things like this, that we needed to pretend that it was strictly related to poverty because our leadership was not going to respond positively to the public health needs of Black and brown Texans. And there are still people who are concerned about that, but we are in a moment now when the expectation and demand of organizations like ours is that we no longer play by those rules, and we can and we must call out the fact that there are these huge racial disparities. So the census just came out with the latest uninsured and poverty numbers last week. They refer to the year 2019, always behind, right? And I just, just one takeaway would be that for Texas households that are headed by a white non-Hispanic person, the median household income is $79,000 a year. And for Black-headed households, $47,000. And for Hispanic headed households, $52,000. So there's a huge difference, in the economic profile for our Black versus Hispanic and white households. And when we carry that over into healthcare, there's so many different ways you can look at this. And one of them obviously is in clinical outcomes, which Dr. Ziebell's probably better qualified to speak to than I am. In terms of coverage, we do have a huge disparity between adults who are uninsured in Texas based on what their race or ethnicity is. So see if I can get down to that. Hispanic adults are more than twice as likely as non-Hispanic white adults in Texas to be uninsured. So they have a dramatically higher uninsured rate. African Americans fall somewhere in the middle. They're about 1.5 more times to be likely to be uninsured. And so one of the things that we'll be carrying into our advocacy, for example, in the upcoming legislative session, is that when we look at the people who are left out, and particularly that our legislature has chosen to leave out of any policy solution, that they are dramatically overrepresented in Hispanic Texans and Black Texans. And we're going to have to call that out. And I think one thing that's useful about this, and it may be useful to this audience too, like a lot of us, we're trying to understand what people are talking about when they talk about structural racism. And I think this is a perfect example of that. It's the kinds of things that get baked into public policy. So our legislature and our governor have not prioritized having an affordable healthcare coverage solution for the working poor in Texas. And who does that affect? Well, disproportionately people of color. That's what we're talking about. It's like no one consciously thought, I'm going to do this because I want brown and Black Texans to not have access to healthcare when they're working in really low wage jobs. Nobody thought that, but it got baked into the system, and that's who's disadvantaged by it. Whereas people who make just a few $100s more a year may have access to the Affordable Care Act marketplace where they can get a really generous subsidy for coverage. So I think there's a huge intersection between race race and poverty, and access to healthcare. And I can't remember, did we put our COVID outcomes in this question too, or was that, so, again, I think the doctor can speak to this probably more eloquently than I can, but I think we've all probably seen that Black and Hispanic Texans are far more likely to have COVID, to be hospitalized for it, and have higher death rates. And there are different statistics from all over the country. Some of them look even worse than Texas's statistics, but we have seen that disparity. And we know that some of it is from people coming into adulthood without a regular source of care.
Right, right. I think that the conversation has really kind of pushed us into the next question, which is great. It makes my job a lot easier. In most of the industrialized world, or the what I would call first world nations, healthcare is a right, and it's provided as a common good by society. There are ongoing debates about whether that's good or bad, depending on your overall political philosophy, I guess. But in the U.S., we know it's been established more as an individual responsibility, and health insurance kind of got its start after World War II, when it was easier for companies to provide health insurance to their workers than it was a pay raise. And it seemed to make sense at the time, and for a long time it worked. But now, particularly during the pandemic, as people got laid off and that sort of thing, they've lost their health insurance if they had it to begin with. So it's, I think, probably if we've never had an incentive to think about how this our system works now, I think the pandemic has forced us to reopen the whole question of how we provide health insurance or health coverage or medical access in our society. From your perspective, what's the ideal relationship between healthcare, government, and individuals? Especially in this time of pandemic. How do we reframe healthcare to improve national outcomes? I'd be interested in your thoughts about that. Anne, why don't we start with you?
Sorry, muted myself. I think that it's probably perfect for a Methodist audience to say that I'm kind of anti-orthodoxy, and the bottom line is there's a lot of models out there in the industrialized world that work well, and the main thing that they have in common that we don't have here is just that they have made that commitment that everyone is supposed to be able to have access to a decent standard of comprehensive health care, and that it's going to be set up in a way that no one will be financially ruined by it. And we have not done that in this country. I think, arguably there's an aspect that's like social Darwinism, where we're just sort of like, good luck. I hope you don't happen to be the person who needs extra help, who has a serious healthcare condition. But I think one of the main things, the question is like the relationship between healthcare, government, and individuals. And I think we need to throw corporations or the economy into that too, or markets. I think part of our challenge in this country is that we have tied our system so much to for-profit components of it, even though not all of it is. And that when you look at the wonderful bar chart that compares us to other OECD countries, to other economically developed countries, and we have by far the highest cost per person, and all of these other countries that we think of as having super high costs of living are, doing it a lot cheaper than we are and having better outcomes. That we know that we have paid a high price for allowing unregulated markets to be such a big part of what we're doing. And I always have to be careful about this when I talk like to physician groups, like I did last week to TMA, which is that in some ways doctors have been kind of left out of that. What physicians get paid has not necessarily been wildly profitable, but there are many other aspects of the healthcare world, including the health insurance marketplace, that are super heavy on, a lot of money is going to stockholders and not to the provision of care. So, we have several relationships we need to look at there. And there are many successful models that still have commercial or market-based components to them, but we're probably the only one where it's so unfettered. And there's no caps on how much profits can be, or on how much executives can be paid, or any of those things. No attempts to constrain drug prices, those sorts of things. So we're paying the price for our laissez-faire approach that we've had to healthcare.
Ed, you're muted yourself. Ed, you're also muted.
Sorry.
that happens.
Operator error. Chris, what do you think about this as a physician you see it in the emergency room, certainly, but you're a physician and part of large organizations too. How does this impact you?
Well, so the issue is, I think if you're thinking about how to really organize a country for maximum GDP or anything like that, you need to have a healthy workforce. And so I do think that the way the current system is designed is very flawed. And I think a lot of people that I've talked to will say things like, well, people just need to buy their insurance, or they need to get it through the marketplace, or they're on their own. The problem is that those people don't understand the reality, which is that those costs get passed on. And so one of the things that if somebody at a party really wants me to blow my mind, they need to ask me why, when I went into the ER for stitches, did it cost me $11,000? Well, that's not what it cost you. That's what the bill was. And the bill was that because we know that we're going to have an insurance negotiation that's going to knock half of that away. And we know that we have to cover the cost of you, plus we have to cover the cost of 3 other people who aren't going to pay their bill. And so all of those costs get baked into the formula for how we charge for services. So I can't just charge you what it costs me to take care of you with a little bit of a markup. I've got to charge you what it costs me to take care of you, plus what it costs to take care of the uninsured, plus what it costs to take care of underinsured people, and so on. And so it becomes more expensive for each of us in that system, because what happens from a societal point of view is, again, as I mentioned in an earlier comment, we let poorer people get sicker before we address their healthcare needs. So the costs that I'm passing on to the people who are better off are much higher costs. So the issue with that is then that we end up with worse outcomes because we let people get sicker before we provide them care, and it costs them more. It costs society more. It costs the percentage of our gross domestic product that goes to healthcare is higher. And then, of course, Anne's comment about how much goes to profit that's not value add for the patient is significant. So when a society gets its head around that and figures out that in the end we're all going to be healthier for a lot less money if we just pay for healthcare outright and take care of people in a proper way, and then we have a nice healthy workforce that can continue to generate gross domestic product to continue the growth of the nation and stimulate the economy. I think one of the things that we're seeing right now, and a lot of people don't want to see it, is just how tightly the interplay is between the health of the people and the health of the economy. And there's this sort of pretending that a lot of people are doing right now with regard to the pandemic and what's going on there. But the reality is that having a lot of people get sick has a devastating effect on our economy. And that's already happened, and we have not even gotten to the point where people are starting to default on their health care bills and declaring personal bankruptcy and losing their homes and that sort of thing. All of that is yet to come. So we're already seeing very significant amounts of people filing for unemployment claims. We're seeing downsizing. We're seeing businesses go under. And that's, to me, that's the water being sucked out into the ocean before the tidal wave comes. And the tidal wave of economic devastation that is a year away from us right now it frightens me as a person who is going to have to exist in this society, but also as a healthcare provider, because everybody's access is likely to get worse because a lot of people are going to lose whatever coverage they have, and that's just going to cycle it down. A lot of people are going to lose their homes, which is going to mean the homeless problem is going to get worse. A lot of all of that is intertwined, and I think that the fact that people are continuing to still want to bury their head in the sand about the tightness of the link between the health of the population and the health of the economy is only serving to make that worse.
Wow. Okay. On that cheerful note, let me continue discussing the Affordable Care Act, which was, has been quite of an experience. It's been in existence now since 2010. There was great debate and discussion about it when it was first proposed. As the oldest person on the screen, I remember the debates about Medicare back in the mid 60s, 1965. I was in high school at the time, and our civics class devoted a day or two to discussing Medicare and how good it was, how bad it was, and the fault lines then are the fault lines now. I mean, people were for it or against it because as either socialized medicine, it was going to be the end of medicine as we knew it, or no, it was going to be a rescue vehicle for people who needed health care but had no means to support themselves or no means to get it. And as part of the Affordable Care Act, of course, there's an opportunity to expand Medicaid throughout the nation. In many states, both Democratic and Republican administrations have accepted that proposal and expanded Medicaid for their residents, but Texas has not. Legislatures have been opposed to it as in their majority. The governors have been opposed to it. So can we have a little bit of conversation, Anne, about, if we were able to expand Medicaid, how would that impact Texans, in the gap that you discussed earlier, where we were talking, people who are too poor to qualify for the Affordable Care Act, but, to make too much money for Medicaid. Would expanding the Medicaid program in Texas fill that gap?
I'm trying to spare you my background noise. As of last week, when the 2019 census uninsured stats came out, they were projecting the 2019 number at 5.2 million. And there have been a number of expert groups that have tried to do some projections about how many folks we've added to our uninsured population during 2020 because of job loss and the loss of employer-sponsored coverage as a result of that. And none of them are perfect or exact, but it's likely that out of a 5.2 million or around 5 million Texans before COVID, we thought that about 1.5 million of those would be picked up by Medicaid expansion. So, because it's only for people below an income that's just above the poverty line, right? So that is the single policy change that would flip the switch for coverage for the largest number of Texans. There are other things we would need to do to reach our higher income Texans. With the addition of folks who've lost their jobs, the Kaiser Family Foundation put out a report a few weeks ago. Maybe it's longer than that. They put out a report recently, and they're projecting that by January, we're going to have at least 2.2 million Texans who are uninsured but could be covered through Medicaid expansion. So it's a big deal. It's a big deal. And some, as I mentioned, as I may not have mentioned before, when you talk to mental health advocates, they will often tell you that that's the number one thing that could reach hundreds of thousands of Texas adults with chronic mental health conditions, many of them mild to moderate, could help them get access to ongoing treatment for their mental health. One of the things lots of people, including, unfortunately, the legislators up under the pink dome, don't understand is that we don't cover adults in Texas Medicaid. We hardly cover any parents. On any given day right now, there are 3.2 million children on our Medicaid program, and only about 150,000 of their parents qualify. So we don't cover most parents, and we don't cover people just because they're poor and uninsured. Not only that, but we don't cover people even if they have a very serious chronic illness, and it can even be a life-threatening chronic illness. Unless you're going to die within a year or you cannot work at all, you can't get disability-based Medicaid. So that leaves tons of people with mental illness out. The other thing that we have, is that our maternity coverage for Medicaid, which delivers about 55% of the babies in Texas, you get it once you have a positive pregnancy test, and you lose it 2 months after the baby's born. So we don't have the opportunity to get women healthy before they conceive, and we don't have the opportunity to take care of them afterwards if they have any of a number of health conditions, including postpartum depression, but lots of other things come up too. And most of the biggest source of maternal deaths, from 2 months postpartum to 12 months postpartum is overdoses. So, and suicide. So, I mean, it is a critical part of addressing maternal health too. So it could make a huge difference in the well-being of people. If I have a chronic illness, whether it's mental or strictly body medical, it's going to affect my ability to work and my ability to earn. That may be the whole reason why I have an income below the poverty line, which under the Affordable Care Act means I can't get subsidies in the marketplace. And in Texas means I can't get Medicaid either. I remind you, Ed mentioned most states, or a lot of states, have done Medicaid expansion. 38 states have done Medicaid expansion. Texas is at the bottom of a list that's not particularly distinguished. And while you will hear people complain about Medicaid, and it does have shortcomings, many of which our legislature created, I can assure you that everyone who's on Medicaid in Texas almost everyone is profoundly grateful for it. And the whatever glitches we have in our program are glitches that are well within the power of our legislature and our governor to fix. I do want to mention the Kaiser Foundation has great information on the consequences of not doing Medicaid expansion. And one of the things, as I alluded to earlier, is that our adults who are uninsured today but could be covered by Medicaid expansion, they are 57% Hispanic and 13% Black. So, again, our choice not to do this Medicaid expansion and to just essentially leave our working poor families, who we kind of want to pretend that there aren't any working poor, that if you're working full time, or maybe even have 2 full-time earners in your household, that you're not going to be below poverty, but you can be. And particularly if you have a bunch of kids, or if you're later in life and have a chronic illness. So the decision not to do that has a racist outcome. And that's why I go back to the comment I made earlier about, if we're trying to understand what is a practical example of structural racism, that's one of them. That's one. And I think that's probably enough. Why don't I hand it back to the doctor?
Chris, do you have additional thoughts about Medicaid expansion, how it would impact who you see in the emergency room, or how often they would come if they were getting primary health care someplace besides the ER?
Well, certainly it's common for me to see the folks who fall through the cracks. So anything that we can do to shore up the support system for folks is going to help them to get better. I took care of a fella a few days ago who came into the ER in active alcohol withdrawal. he was sick from alcohol withdrawal. He needed medications for that. He needed enough medications that he was going to need to be hospitalized. I looked in his record, and in the last 2 years, this was maybe the 7th time that we've hospitalized him for active alcohol withdrawal. And so I sat at his bedside a little while and took some time to build rapport and trust with him. And I asked him, what can we do to interrupt this cycle? And he said, honestly, I really don't know. I want to quit drinking. I have wanted to quit drinking. I end up here when I run out of money and I can't buy alcohol because I have nothing else to do and I'm going through withdrawal. And you guys will get me over the acute withdrawal and you will make me medically stable, and then you will discharge me to nothing, and I won't be able to get therapy. I won't be able to get treatment. And within a couple of days, I'm going to be drunk again. And that's the difference. If I had, this is a motivated person who, if I could get him the proper support, to get him the proper therapy that he needs to help himself develop and maintain a life pattern of sobriety, he would be better off, and we would be better off, because this is his 7th ICU admission in 2 years. And he's got nothing to pay for that with. And so we as a society eat that. And so that's the money that ends up coming back to the hospital in terms of tax dollars through the healthcare taxing district or things like that. And we all would rather spend that money on managing diabetics in the outpatient setting. We'd all rather spend that money helping a schizophrenic to get on a medication regimen to where they actually maybe could be somewhat functional and have a job. We would all prefer to spend that money in another way, but that's not the choice that we have. Because he came in with a medical emergency. I'm obligated by law to take care of a medical emergency until it's stable. And our obligation ends when it's stabilized, and that's when he gets discharged to nothing. And so that's an opportunity really for where, if you think about Medicaid expansion and just creating the opportunity for him to have some coverage to get some help, that would be cheaper for everyone and better care, and it would free up resources to do other things. And I'm not even going to mention how many times he's been incarcerated in that 2 years at a cost there on that side as well. And so all of that is us actively choosing not to do the right thing and seeing the consequence of that. And I think that the motivations that I've heard, the political motivations for not accepting Medicaid expansion, frankly, are very ego-driven, by people who just, I would rather let my population die than let somebody else tell me what to do. That seems to be the fact that Medicaid expansion comes with strings that has found the resistance that it's found in Texas. And in my position, I find that appalling, because I see the consequences of that, and I recognize that it's just dumb decision making, and it ends up costing us a lot of money. Ed's heard me say this before, but I've been in a lot of forums where I talk about the spending on mental health, and people will complain that Texas is 49th or 50th in the nation when it comes to spending on mental health. And I always raise my hand and I say, no, we're not. We've got the 50th worst accountants, because they're not counting jail time. They're not counting ICU time. They're not counting how many stitches I put into wrists. They're not counting any of that. They're only counting how much do we spend on outpatient care. And if you actually added up what we're actually spending, you would see that we can save a ton of money by doing it right. I'm actually going to give a talk later this afternoon on a success story here that it was an experiment that Dr. Mark Hernandez did here in Austin when he was running the community care clinics. And what he did is he decided to look at a patient population, specifically people who had asthma or emphysema. There was about an 18-month waiting list for people. Once you were diagnosed with emphysema, it took about 18 months to get in to see a pulmonary doctor for the very first time. And because the waiting list was just so long. And on average, those people had 3 or 4 hospitalizations in that 18 months, which the medical assistance program paid for. And then they would go out to their primary care doctor and whatnot. And then eventually, after 18 months, they'd get in to see a lung specialist. who would then put them on a regimen run by a specialist and finally improve their quality of health to where we could curb the pattern of hospitalization. So Dr. Hernandez's experiment was to say, I'm going to offer the community of lung doctors Medicare rates for taking care of people who are in the community care program. Within a couple of months, the waiting list went from 18 months to 4 days. And the hospitalization stopped, and the amount of money that the community saved by paying more was extraordinary. And so we're going to tell that story to the Dell Medical School people and the medical community a little later today. But it's an example of spending money right saves you money in the long run. And I think that the ego-driven, stubborn, I'm not taking Medicaid because you're going to try to tell me what to do with it, is only hurting people. And I wish we'd get over that.
That is really astounding data. I mean, it doesn't surprise me at all. It's nice to have the data, and maybe with the facts we can get some attention and get people, some of the policymakers, to pay attention to it. Because if you spend a little more but save a lot more, that's what they profess to want to hear. We'll see. One of our United Methodist Women's Circles, it's a group of women who come together periodically and take on mission projects within the church, is very politically active, and they're advocating for policies to improve maternal mortality rates in Texas, especially for women of color. Chris, let me ask you, because I'm sure you see in the emergency room at least a handful of women show up who've never had maternity care, and they're in trouble. What kind of impact would it have if the state were to address maternal health care? Anne mentioned that women, once they get pregnant, might be able to qualify for Medicaid. They may or may not know about that, but what kind of difference would it make in presentation to you if they had proper prenatal care?
Well, we know that having an established prenatal care provider starting at some point in the first trimester has a pretty tremendous impact on improving the outcomes for the baby being born, appropriate size with good healthy lungs and good healthy heart and so on. So any kind of advocacy that generates that kind of access to where people can get that is very important. It doesn't take much investment on the front end. A simple prenatal vitamin started in the first 2 months of pregnancy can affect the rate of spina bifida and other birth defect abnormalities. And again, all of those things have costs. So if a child is born with a neural tube defect and ends up paralyzed from the day one, that's somebody that's going to be dependent on society for decades. So there's probably no more impactful place to make a difference than in terms of perinatal care and making sure that folks get what they need along the way. Controlling mom's blood pressure, controlling mom's blood sugar all have an effect on the health status of the baby when they're born, and that translates through to how much that child costs us as society. Now, a lot of those children may be born and end up on Medicaid, and if that happens and they're born diabetic or with a birth defect or with cerebral palsy, that expense is going to be tremendously more, and we're going to wish that maybe we would have let that mom have 6 visits with the doctor and take a vitamin, as opposed to paying all those expenses forever down the line. So that's I see people who show up and their blood pressure's uncontrolled or their blood sugar is uncontrolled, and in the middle of that hypertensive, sugar hyperglycemic factory a human life is trying to grow.
Excuse me, Anne. I know that's something that you have talked about for decades, maternal health care. And is that something else that you are, that every Texan is going to be looking at for the next legislative session? Mute.
Myself. We actually had legislation in our last legislative session in 2019 that would have would have had Texas seek to, instead of cutting off women's Medicaid 2 months after the baby's born, extend it for a full year from the birth. Most people who supported that also believe that Medicaid expansion would be even superior to that, because as I mentioned before, you could have mom having access to birth control in advance, having access to a medical home where ideally she could be as healthy as possible when she conceives, as well as not having to worry about losing access to various things after a baby's born. So, but I think all advocates, even if they see the full adult Medicaid expansion being the gold standard, agree that if we can make an improvement in maternity care, that will also be beneficial to moms and to babies. Both of those things are going to be on the agenda for this legislative session. Last session, the Texas House approved that Medicaid maternity extension, sent it over to the Senate, and the Senate just let it die. You know, that was what they chose to do. We're hoping maybe we will have a more open attitude towards some of these coverage issues. One factor being that, you know, if we have 1 million or maybe even more, maybe 1.5 million newly uninsured Texans, folks who've never used any public benefit before and suddenly found themselves without income, you know, that maybe we're going to see a different attitude towards how important it is and how reasonable it is for our state government to play a really active role in making sure that every Texan has access to comprehensive and affordable coverage. That's not necessarily gonna, you know, Dr. Ziebell's alcoholic client that he talked about, patient that he talked about, you know, that's your worst case scenario. But as he knows, there are some cities and areas that have really targeted trying to make sure that all the needs of somebody like that are being met, that they aren't being discharged to nothing, like he said. So there are solutions, you know, that we can make both for the folks who just, you know, who would use a system and would take to a medical home if they had the opportunity, as well as a system that, by providing a financial structure for treating that alcoholic and not discharging him to nothing, but having access to mental health services and to treatment, you know, those things could all be changed. And maternal care is a huge piece of that. And I think that we have vastly underestimated, you know, we've prioritized covering children and neglected their parents. And I think we need to recognize that parents can do a hell of a lot better job of parenting and of being employees, you know, if their healthcare needs are being met.
Yeah. Well, thank you to both of you. I think we're just about to run out of time for our recording session here. We really appreciate your taking the time out of your day to talk about healthcare and policy, and in a tradition of faith is what we are as a church are trying to do. Do you have any last thoughts or comments or anything that you'd like to share with us before we say amen?
You know, I think I mentioned early on that I may have mentioned early on that I dropped out of medical school and discovered that I cared more about the social justice aspect of medicine. And I think one of the things we realize at my office is that having access to affordable healthcare where there's some kind of cost certain for you, that you will not be financially ruined by your medical expenses, is just a huge part of having a legitimate claim to equal opportunity. You know, if I can't work my way out of poverty into the middle class, or hold on to my position in the middle class because I'm always at risk of medical bankruptcy, we just don't have that equality. And we're we took some steps in that direction with the Affordable Care Act, but as we all know, there's some big holes in it, maybe bigger holes in Texas than some other places. But I think, really recognizing that, access to healthcare is part of economic justice and social justice. I hope is something that, people will spend some time thinking about.
Oh, that's our goal, is to spend time thinking about it and find ways to act upon it too. Chris, any final thoughts?
Yeah, I think that being in the time in history where we are right now is going to have a pretty big impact. I think there are things that have been not easy to ignore, but have been ignored for a very long time. And I talked about the tidal wave that's coming. The advantage of a tidal wave is that it washes the beach, and I think we're about to really expose some things that won't be able to be ignored anymore. In my job, every day this year, we've talked about the need to be transformational, how we have to adjust to the new volumes. We have to adjust to the fact that people are scared to come to the hospital. So we need telemedicine solutions. We need technology solutions. This is a period of amazing change in terms of how I do my job. And I think it's my industry is not alone in this. Every single aspect of our lives is going to have to be reinvented as a result of what's going on right now. So I recognize that we're at a period of pretty significant political extremes, but reality is going to force us to come together to survive, and we're going to have to find common solutions and common ground. And so I have more optimism and hope as we head into the election season than I had before. I think that the majority of people that I meet, even if they swing one way or the other, understand the common ground and are going to really start insisting that our leaders find that common ground and stop working from the opposite poles.
Well, those are encouraging words. Again, thank you so much for participating. Since we are a church, I think I'll close us with a prayer, if you don't mind, and would join me. This is a prayer for justice in healthcare. O most divine healer, you healed those who approached through a gentle touch or word. None who came to you were denied. Let your justice roll down on this country. Let it convert those who place wealth above health. Bless those who are ill, needing treatment, but who lack the money to pay for it. Let this country's government serve its people, not corporate interests. Bless those who are today's healers, doctors, nurses, and all medical staff. Let them be filled with your mercy and compassion as they touch the ill, the suffering, the dying. Bless them in their mission in service to all. In Christ's name we pray. Amen. Amen to you all. Thank you so much. We appreciate your participation.